I want to take a few minutes of your time to talk about another critical care presentation, and that's chest tube. We previously talked about collapsed lung. Well, one of the remedies for collapsed lung is the insertion of a chest tube. It's called a closed drainage system. There are 3 chambers in the chest tube. There's the water seal, the wet suction, and the dry suction. You as a nurse will actually put the water in for the water seal. The water seal can rise and fall when the patient coughs or when they deep breathe, but normally if it's continuous bubbling, this is a classic question about the water seal, then there's a leak. So let's review once again. Who has a chest tube? A patient that has collapsed lung. We've already talked about collapsed lungs and what happens when the lung collapses. Fluid can get in there, such as blood, secretions, and air can get in, and also mucus, also called empyema. This is the tip that the doctor is going to insert. Your role, get consent. Prep the area with iodine, make sure they have no allergies. Medicate the patient for pain. Be sure they have no allergies to cane drugs too, because the doctor will use lidocaine and he sutures the chest tube into place. The patients are usually presenting with shortness of breath. We talked about that already, accessory muscle use, and distended neck. Veins, also when you auscultate their lungs, you will hear dull or no sounds on the side that's collapsed. Once the chest tube is in, you put the water in for the water seal. You attach it to wall suction, okay? These are your roles, okay? This is showing you negative 80 millimeters of mercury wall suction. You have to keep the chest tube dependent below the patient. Keep the patient supine or semi-Fowler's or Fowler's position. Post-procedure, you're going to make sure that the patient deep breathes. You should have taught them how to use the incentive spirometer prior to surgery. You're going to keep checking the water seal every 2 hours. You're going to document the drainage the first 24 hours and then every 8 hours. Let me repeat that. You probably see a lot of drainage initially. So you're going to document the drainage the first 24 hours and then every 8 hours. Here's the drainage here. If the drainage is more than 70 milliliters per hour, you need to tell the doctor. You're going to check the tubing for kinks. You're going to listen for any air leaks. You're going to check for subcutaneous emphysema around the site, which is also called crepitus. You have to keep the chest tube below the patient. At bedside, in case the chest tube falls out, you're going to have 2 hemostats, you're going to have sterile water and inclusive dressing. We do not strip the chest tubes anymore, and we do not clamp them. We make sure the patient does their breathing. We do a chest x-ray before we remove it. When the patient's ready to have the chest tube removed, you ask them to bear down. That is the Valsalva maneuver, and that helps with the lung staying inflated. Then you put an occlusive, bulky dressing on the site. Well, that's basically it in a nutshell. Chest tubes can be quite problematic. It's your observation and understanding of the physiology of this unit and what it's doing, and you're teaching the patient and properly medicating them, as we talked about before, for the lungs to reinflate. It's contingent on the patient also deep breathing. The wall section and the water seal is not enough. The questions they will ask you, continuous bubbling, problems, okay, leak. The questions they will ask you, rise and fall with breathing is normal in the water seal, or coughing, all right? I think that should cover everything you need for ATI. Thank you for your time.